I hope even if you have some experience that inshallah you'll find interesting. If there's something in particular you want me to comment on during the presentation, feel free to raise your hand, but otherwise we can also do it towards the end. I don't have any financial disclosure with any of the instruments or companies. So what I hope to do is to initially emphasize the value and a little bit about the history of OCT, but then focus on, okay, what is the quality? How can you tell the quality of a good scan versus a scan that is not so good? And of course, artifacts, because if there are artifacts, we need to recognize those. And then focus on glaucoma, more on RNFL and some on ganglion cell analysis as well. And the importance of structure and function correlation so that we situate the OCT within the whole patient and the entire structure function aspect rather than just look in isolation. And also some comments on progression. So as we know, for many years we had time domain OCT, and the resolution was about 10 microns axial resolution. Now with spectral domain, which integrates all of the data simultaneously, we get 3 to 6 micron resolution. So the resolution is extremely good, and here's a comparison. If you look at the deeper layers, often we can tell the layers quite precisely, and it's near histological definition. So it's quite remarkable. And of course, our retina colleagues also use this a lot, and there's some use in the anterior segment as well. Now, in the anterior segment, we tend to focus more on the angle with glaucoma. However, if you have this capability, you can look at the cornea and you can look at the iris, etc. The problem, of course, is because there is light, it does not penetrate the iris, right? So it is not as good as ultrasound biomicroscopy, which uses ultrasound to look at the ciliary body or what is behind the iris. But looking at the actual angle structures, the anatomy is quite useful. As we were mentioning in the last session, it is not a substitute for gonioscopy, because with gonioscopy you can see how much pigment is in the angle, any new blood vessels, small PAS and so on. With this technology you can tell if the angle is open or closed, and you can identify if you have high resolution, even Schlemm's canal and collector channels. So I think it's worth looking at this if you have the technology. And although I will not spend too much time, I think the important thing is to identify the scleral spur when you are looking here, which is the convergence of the innermost aspects, and then see if the angle is open. And the trabecular meshwork and Schlemm's canal is about 500 microns in range and about 500 microns from the root here. So if this is the scleral spur, this is the meshwork here. And in this case, you can see that the angle is actually quite narrow over here and almost closed on this part. So you get some idea. And you know, if you're looking at plateau iris, for example, after iridotomy or iridectomy, this can be very helpful as well. So I just want to emphasize here that just like we look at a visual field and look and see, is it the right patient? Is it a reliable visual field? What does the grayscale tell us? What does the total deviation tell us? In the same way, an OCT scan can be looked at, and to make sure that it has the right information. Otherwise, we spend time interpreting, but it may be the wrong information. It may be the wrong patient. There may be an issue with regard to the signal strength, and we can talk about signal strength in a minute, and we can talk about quality in a minute as well. When you look at the color map, the heat map, it is somewhat similar to the grayscale. It gives you an idea of what that scan is going to look like. And then when you look at the average nerve fiber layer thickness, it is almost like the mean deviation. It gives you an idea overall of what is happening. And it's a pretty good index, but one has to look at the details as well afterwards, not only the mean deviation or the average RNFL. So there are some similarities. And also the age of the patient has to be entered properly. Otherwise, the adjustment in the field is not good for total deviation. Similarly, the adjustment for calculation of average nerve fiber layer may not be correct because there is a small age-related attrition as well. So when you look at the quality of the scan, I just wanted to emphasize these 5 things. One is the signal strength, and different machines have a certain quality cutoff. So if you have the Cirrus, for example, more than 6 is fine. For Spectralis, more than 17 is okay. For OptoView, more than 29. And these are just approximate values, but you have to know your own machine and what is the reasonable signal strength, okay? The centration of the disc is also important. The quality of the image that you see in the blood vessels, the disc is important. And I'll show you some examples of problems, such as a blocked signal where there is an issue. The segmentation of the nerve fiber layer needs to be done properly, and if it is not done properly, you can manually adjust it to make sure that it is okay. So just like visual fields, we have the reliability index, the quality check. These 5 things need to be checked for quality for OCT. So here's an example of a patient, this is using one particular technology, but again, your machine printout will be different. This is the Cirrus, technology. And you can see a lot of numbers, a lot of information here. But if you look at the signal strength, you will see in the right eye it is, I think, 6 out of 10, right? And in the left eye, it's 4 out of 10. Now, why is that? Well, there is some area where there is a rectangle of missing information, okay? Now, that could be because of movement, blinking, so many different things. But there's definitely missing information. So when the analysis is done, right, it is showing you all this red spot and dips. But really, this is all capturing missing information. So it is not very useful. So it's better to take time, make sure the technicians know that ideally we want to improve the quality to at least 7. And if you do that in this particular patient, after some lubricating drops, some instructions, you can see the information is much better now. So it is still low, but even the average RNFL, you can see, has gone from 49 to about 64, okay? So the 49 was quite misleading. So it is actually closer to the mid-60s, and there is better information, and you can see there is still some thinning, superiorly, inferiorly, and so on, but not as bad as the previous one. So, and this was simply, with some instructions to the patients and some artificial tears. Here's another example, when I was in Edmonton, of a patient who had a scan done. And if you take a look here, there's a problem, right, with this scan. What is the problem? It's not centered, right? So this nerve should be in the center of the ring, right? Or the volumetric scan. And if we center, now you see a much better profile, right? Double hump profile of the retinal nerve fiber layer. Before, it was showing quite a lot of drop inferiorly, superiorly because of the problem with centration, and now it is showing a much more normal looking scan. This is an example. Now, this particular paper by Dr. Carden is in neuro-ophthalmology. Okay, it's published 5-6 years ago, but it's quite a good paper, especially those of you that want to study artifacts in more detail. So there is a problem you can see with this right eye. The view is not very clear. So there is probably something in the media that is creating a problem. And because of that, especially down here, it is giving us an artifact, okay, in this area. So there is a disruption. So if you look at the segmentation, right there, there's information missing because of this area here, right? If there is something that is not anatomical on the retina and it looks like a rectangle or triangle or something weird, it is probably something in the media, right? Missing information. So this actually happens to be a case of asteroid hyalosis, right? And the asteroids are blocking the scan. So you can have some block problems as well. You can see in the other eye, it's completely fine view. And even though there is a reduction in nerve fiber layer, the quality of the scan is much better on that side. The signal strength, I think, on the right is also flagged as being abnormal. The other thing that when you're doing the RNFL, and that is the circumpapillary scan, right, is the floor effect. So Joel Schumann, who is one of the inventors of OCT, the technology was developed by Massachusetts Institute of Technology, MIT, with Carmen Puliofito and Joel Schumann. And those guys were also at Harvard and Tufts and so on and worked with MIT. So what they were saying is that when they studied this technology, there is a floor effect for the ganglion cell nerve fiber layer. And most likely that is because after some time, whether it is glaucoma or some other disease, there is thinning and you cannot pick up any additional loss of ganglion cells because of glial remodeling, some scar tissue in that layer. And the floor is somewhere around 50 microns, in some machines maybe 40 microns, which means that in advanced glaucoma, if you're just using the nerve fiber layer, you're not going to be able to have enough dynamic range to pick up a change. So at that point, visual fields would be helpful, but also ganglion cell complex, right, may be helpful. So here's an example of a patient with advanced glaucoma, 30-2, and you do a 10-2, and now you get lots more information to follow the patient, right? So you can use different strategies and information. You don't have to rely only on one technology or test. Why are the ganglion cell analysis in the macula so useful? Because when we look at the overall ganglion cells, there's a large variation amongst normals, but in the macula area, the fluctuation is much less in terms of ganglion cell count, and that is the highest region, of course, of ganglion cells. So it is worth looking at that area in more detail, and you can do it, with the machines that you have probably. One thing you have to keep in mind is that it is good to do internal confirmation. So, for example, if you get a nerve fiber layer plot and you see something, you can actually see it on the ganglion cell layer as well, usually in the same area down below, for example, or up above. There are also artifacts, for example, myopic patients, right, axial myopia, have a very thin, eye wall, but also thin retina. And so the ganglion cell layer may be quite a bit thinner in those patients. So it's good to do the internal confirmation or correlation and know what your refractive error is as well. Here's an example of an internal confirmation where you see this particular area of thinning in the ganglion cell complex. Now, the machines will have different ways of calculating ganglion cell layer with or without the inner plexiform layer. If you have the same machine each time, it's useful, of course, for registration. Otherwise, people keep switching hospitals or machines. It can be difficult. So you can see that there is some loss of nerve fiber arcuate-shaped bundles down below, which is showing in the ganglion cell complex. And this is showing the area of loss. And here is displayed through the retinal nerve fiber layer, a similar pattern in the infratemporal area. So there is a confirmation that the retinal nerve fiber layer inferior temporal loss correlates with the ganglion cell layer loss. Moreover, you would expect a supranasal, right, scotoma, and there is a supranasal scotoma. So this is a good example of internal structural correlation for the same patient as well as a correlation with function, which you often see. Sometimes it may not be there. Let's look at some artifacts, because if the macula is important for ganglion cell layer, the macula, as you know, is subject to various things. Here's an example of a condition where it looks very thick, right, up here. You see the segmentation includes this layer, but actually you need to subtract this aspect to get a proper segmentation. So what is this here? One of Dr. Mayer's favorite subjects, epiretinal membrane. And recently he shared a nice papers from the frontiers of ophthalmology, which looks at subtracting out the effect of the epiretinal membrane and trying to improve the quality of the scan. The problem here, of course, is the membrane may also stretch the photoreceptors and the other layers of the retina and affect it, not only structurally, but functionally as well. But here, the epiretinal membrane is creating a thick, artificially thick retina. And so if you look just at average numbers, you may say to yourself, look, this looks fine. But in reality, there are some thin areas, you see. So one thing to pay attention to is not always this red and green, but actually look at the shape of the curve, right? In the temporal, superior, nasal, inferior, etc. plot, T-SNIT plot. In the T-SNIT plot, there should be a rough double hump, sometimes a split hump, depending on whether the arcuate bundles are split. And you can see this is artificially thick, but there is a dip here which is showing some thinning as well. So here's an example of a membrane which affects the ganglion cell complex as well, right, in this area. And so it's showing actually an area of damage when in fact they may not be damaged. So even similarly with macular degeneration, etc., you need to make sure the macular status is healthy if you're going to interpret this. Now, here's another interesting thing. I was talking about artifacts with the myopia, and you can have various artifacts, including sometimes some torsional artifacts if the disc is tilted. But this is a high myope patient, and you're seeing here that the bundles, the arcuate bundles, are splayed temporally. Okay, so there is a little bit of extra, movement of the nerve fiber layer bundles temporally, and it's probably part of the development of the axial myopia. So in fact, because the bundles are shifted slightly temporally, you see the red arrow is pointing to the temporal displacement, okay, of these bundles, superior and inferior bundles. It makes it look like the rest of the scan is actually thin, superiorly and inferiorly, right? But in reality, it's just a normal variation of temporal displacement of the superior and inferior arcuate bundles. So you can recognize that by looking at the pattern and seeing how it's displaced temporally slightly. Then you don't have to pay as much attention to the red and green, because otherwise you would say, look, there's red disease. But in fact, there's no red disease. It's more just a normal myopic fundus, okay? So I think one just has to be familiar. And this paper that I'm showing some figures from actually shows you very nice, elegant examples of different myopic pathologies. OCT can also be good for looking at the boundaries of the scleral lip. Sometimes when we're examining tilted discs or discs with peripapillary atrophy, you're wondering, like, where is the edge of that disc so I can look at the neuroretinal rim. So what it does is it can actually draw the boundary by looking at the edge of Bruch's membrane, okay? And there is an analysis where you can look at the Bruch's membrane on one side and the other side, and then you look at the what's called the minimum width of the neuroretinal rim based on the Bruch's membrane opening. And so this, for example, identifies the Bruch's membrane and uses it as a landmark, and then figures out the width of the neuroretinal rim, okay? Let me just go back. And so it calculates the I think the parameter is called BMO, Bruch's membrane opening, and the minimum retinal width, or the minimum rim width rather, okay? So some OCTs have BMO MRW, Bruch's membrane opening, minimum neuroretinal rim width as a parameter to follow. So it can be helpful. And in this particular optic nerve, you may say to yourself, I'm not quite sure where the edge of the disc is. So the machine identifies it based on Bruch's, and then it looks at the rim thickness and actually displays the rim width thickness all around. And that parameter BMO MRW has been shown to correlate with progression also over time. Here's a case which is interesting, where you see this right optic nerve has had a problem, and this left looks still pretty good. In the right side, the Goldman type or octopus type kinetic perimetry shows loss of the nasal field, right? And here you can see quite a bit of pallor. And yet when you look at the actual plot of the nerve fiber layer, it actually looks like the right eye has a pretty good double hump pattern. Okay, so why is that? I mean, it looks kind of green, almost normal here in the right eye, despite what most of us would say is optic atrophy, right, or pallor. So if you look at the left eye, and you take a look at the left eye, you will see that the left eye actually has a very thick nerve fiber layer. And the average of the left eye, you can't see the numbers, but is over 100 there, okay, in the normal eye. So there is 30% loss of nerve fiber layer thickness in the right eye, right? But when you plot it and you look at the loss, it still shows within the green. But the key thing to keep in mind, so if you just look at this, you would say it's pretty normal. But knowing this and knowing that the other eye is extra thick normally, right? The 30% loss still looks like it's in the normal range, but it actually is a significant loss. So it's just to illustrate the importance of looking at the fellow eye and comparing what's normal when you have, you can't just look at one eye in isolation, and you cannot just look at the numbers in isolation. You have to look at the whole picture. The other thing that's important is the size. Now, different machines will give you size in different ways. So, in a very simple way, we can look at size by using a 60 diopter lens, for example, which should neutralize the eye, then measuring with the slit beam, or use the, ophthalmoscope, etc., to estimate or the width of the blood vessels relative to the disc. Here, some of the machines actually give you the size, and you can see that this particular parameter here in this plot, the disc area, is almost 3 millimeters squared in each eye. So the eye has what's called megalopapillae, a big optic nerve, right? So when you have a big optic nerve, I think all of us know that you can have a big cup because the same number of axons distribute themselves on the sides. So this is actually more of a physiological rather than pathological disc. And if you look at the rim, it still looks pretty even all the way around. You might say to yourself, look, there's some problem here, right? Superiorly and inferiorly. But this is actually because of the way the blood vessels come in, rather perpendicular, with the vascular pattern is almost 90 degrees as opposed to oblique. So it creates artifact also. So this is not actually real pathology, it's just a bit of artifact. And if you look at the nerve fiber bundles and the segmentation, it all looks pretty good. And this is a pretty normal physiological rather than pathological disc. So it can be helpful when you are thinking, on a suspect. You look at a disc like this, somebody maybe sent it to you, patient is already on drops. Is this actually glaucoma or not glaucoma? It can be helpful along with your other parameters. Now, this is a very interesting case that I showed one time as part of a visual field workshop, but I want to show it to you because it includes some interesting information which we got through OCT also. So this 18-year-old patient was referred in Canada to me from an optometrist, and the optometrist thought that maybe she has papilledema. And she had no symptoms. She was in good health, a little bit overweight, and this was the visual field. So when you look at the visual field of the right eye, and this is the left eye, you might say to yourself, look, there's a little bit of a large blind spot. Okay, maybe there's a little bit of nasal depression in this left eye, inferior depression. But it's not striking, but it's not completely normal either. But the blind spots are also enlarged. So, the differential diagnosis of a large blind spot would include the optic nerve problem, peripapillary problem. So it could be any of these things, in terms of differential diagnosis. It can even be an artifact related to the wrong trial lens or this type of thing. So let's keep that in mind. And this was the appearance of the optic nerve 10 years ago in this particular patient, okay? So this is the right nerve and macula, a little bit of a larger view of the right nerve, and the left nerve as well. So this is the left nerve and macula and the left nerve up close. And this is actually, at that time we had time domain, right? Not spectral domain. So this is the time domain map. And this is a cross-section view of the nerve. Sometimes we forget to look at the nerve cross-section, but that's also useful information. So what is happening here? Is this papilledema? Is it something else? What clues can you get? Well, first of all, it's a tough case, right? Because the disc margins are quite blurred. So it could be papilledema, it could be something else. However, the fine blood vessels on the disc, are still pretty good. Because usually if you have this much swelling, those small blood vessels are not visible, right? So I wasn't convinced that it was papilledema. And the other thing is that the nerve fiber bundles are quite thick. And when you look at the disc, it has this rather a lot of protrusion from the disc. So we followed this patient and we also did some scans. And this was a CT scan. So you can see there's some highlighting here, and most likely this represents calcium. Otherwise it would not show up in the scan like that, right? And the opening pressure, we did the lumbar puncture also, was 9 centimeters. Okay, so it wasn't very high. So these were old time domain scans year after year, and they did not seem to change much. So in the old machines, you could superimpose the scans like this, and this was year after year, and it looked pretty good. Then about 5 years later, we had the new technology. So we did the scan with the new technology. Again, you can see extremely thick, nerve fiber layer over here in the right eye, less thick in the left eye. And here's the plots, on another color map. And here's the appearance of the discs as well. So the discs are beginning to change a little bit, but they haven't changed that much. And when we did the visual fields, we were kind of surprised that the fields look quite a bit worse, right? You're starting to get overall depression, maybe nasal more than temporal, and even in this eye, some diffuse depression. This does not look like necessarily glaucoma or typical, idiopathic intracranial hypertension, etc. So there's something strange about this particular field as well. We did the ultrasound, which also shows enhancement, suggesting possibly drusen. So then we did continue to follow the patient in 2019. Again, you can see the fields are looking fairly depressed, not just the blind spot enlargement, but more. And in 2020, surprisingly, the fields are better. And this is the appearance of the nerves now. So I'll just show you the, see, this is the sequential plot of the average nerve fiber layer thickness in the right eye, and this is the left eye. And so you're seeing that overall it's fairly stable. The right is a little bit thin compared to the left. And the visual fields actually were, the initial ones I showed you looked worse, then it improved a bit. Here's the optic nerves over 8 years. This is the right eye and the left eye. And you can see now that there is a maturation process probably going on with the drusen, because before they were buried, and now you can see some crystals and, the more classic disc drusen. So most likely, this is not a case of something serious from the brain, papilledema, etc., or intracranial hypertension, but rather disc drusen. And the OCT is helpful to follow the patient, and also the cross-section of the OCT can be helpful as well. I'll just pause there for a minute. Any questions before we go on, or it's a bit of a challenging case? Okay, so now structure-function correlation. Okay, so here's large discs again. Is this normal, abnormal? You would say, putting on your optic nerve hat, that there is some abnormality, and the abnormality is showing some thinning over here, but also here clinically. So there is some thinning visible. The visual field shows inferior depression, paracentral depression, maybe partial arcuate, which correlates with the supratemporal loss, right? And when you look at the T-SNP plot, there is depression here supratemporally in the right and left eye. So there is structure-function correlation, which generally is a good thing. Otherwise, if there's no good correlation, then you have to ask yourself, is this an artifact? Maybe repeat it. When you're getting a baseline OCT, it's good to repeat it a couple of times to get a good baseline, because the future progression algorithms will use a couple of scans to get a baseline. Here's an example of that same patient right eye, and you're looking at the change over time, okay? And so it does seem like there's progression, and if you look carefully at the plot, right, you're seeing that inferiorly it is getting a little bit worse here. And the color map also shows that, and superiorly there is more of an arcuate scotoma as well. So it does look like there is progression in this patient with structure-function correlation. Just like with visual fields, you want to repeat it to make sure sometimes, depending on the quality of the scan. But if you see, for example, a notch and the RNFL confirms that, or the ganglion cell complex, then you don't necessarily have to repeat it. So many guidelines talk about an average change over time in the ganglion cells, but if it's going slow, it's not a problem. But then there's a line, and when you lose ganglion cells beyond this critical amount, then you're starting to have effect on the quality of life and the function. So what we want to do with glaucoma therapy, of course, is to slow down or prevent loss, and especially you want to prevent fast progression. So you can check this progression on structure or function mapping. So here's an example of a patient where this is the visual field at baseline, and then this is the visual field some years later, and you can see quite a lot of progression in the superior field. In visual fields, we use a combination of trend analysis. So we could use MD or VFI. Here's visual field index going down. So clearly there's progression over 8 years or whatever the time interval. And here's event-based analysis based on early manifest glaucoma trial showing that each of these points are getting worse also. So there is pretty good evidence of progression on the function. And when you look at the structure over time, almost the same time period, you are seeing evidence of some change as well in the inferior area. This is the average nerve fiber layer. See how it's going down? But the inferior is going down very quickly compared to the other areas, okay? And here's the plot of one over another, and you can see progression as well. Now, these quality of the scan is pretty good, and the quality of the fields are good. If the quality is not so good, then you need to make sure you don't have the artifacts there. Like in visual fields, we would not get a clover leaf or some reliability problem and use that as a baseline. And the same is true of the OCT scans. Here's an example of an OCT where the signal strength is only 3 out of 10, and you see this artifacts here. The rest of the scans are also not extremely good quality, but better than this initial scan. If you look at this and you say to yourself, look, it's getting worse, the patient is getting worse, in reality, that's probably not true. So what we did is we went there and removed the old scan that was poor quality, 3 out of 10, and then repeated the progression analysis. And now you can see that each of the curves are superimposed one on the other. And actually everything looks pretty stable. So there is no progression here. That was just based on the poor signal strength and quality. And the same with ganglion cell progression. You can look over time, and if you see a change, it's better to confirm it. And it does look like there's confirmation. In fact, it's getting even worse. You can look qualitatively, quantitatively. You can look at the tables. So there's a variety of ways of looking at progression analysis depending on what you like to see, qualitative, quantitative, but also the machine parameters. One thing is the shape of the curve. So Dr. Schumann is a big believer in looking at the actual plots and not just the standard sort of color-coded maps, okay? So I'll show you an example of a 68-year-old patient who had asymmetric glaucoma, and she had trabeculectomy 10 years ago in the left eye, but in the right eye, she was being monitored, and her pressures were pretty good. I mean, the left eye was 6 because of the trabeculectomy, but on the right eye, she had a prostaglandin analog. Pressure was down to 12. So now let's look at this 68-year-old patient, and here is the visual field. I mean, the left eye, of course, is not very good, but that's the one that had trabeculectomy. The right eye, the nerve, you would say probably is not too bad, although there is some sloping here, and the field is still pretty good. All right, so let's see what happens. So this was many years ago, and I want you to watch this area here, okay? This is the circle plot, and look at this peak over here. And let's see what happens over the years, okay? So you're seeing some change, and now it's showing up as a little bit of thinning infrotemporally. Okay, so when you look at the plot one after another, you see there's a small change infrotemporally, which shows up on this color map as well as the segmentation T-SNP map. So there is some change going on, but if you just looked at only the color map, you might say everything looks pretty good. Maybe this is a problem, but when you look at the shape of the curve, okay, I'll just take you back one more time. So look over here at the shape of the curve. You'll see that the curve shape is changing, and that's a clue that there may be something going on in that area. So don't always say, look, it's in the green, it's normal. Just look at the shape and the change over time as well. And there is a subtraction map which shows quite a significant decrease in nerve fiber layer infrotemporally. So look at the puzzle and the clinical picture, whether the patient is noticing change, are they monitoring themselves, how is their quality of life, is there a correlation with structure and function, and you have time to repeat the testing also. You don't have to make a decision straight away based on that one test. Just in the last few minutes, I wanted to highlight some additional things that are here and even more exciting in the future, and that is looking at the lamina, cribrosa in more depth using spectral domain, and we can get information about the anterior and even deeper layers of the lamina cribrosa. So this is enhanced depth imaging using standard OCT, and then with the what's called EDI, you can see laminar defects, almost like micro pits. And these are actually evidence of damage or progression. So in the future, we'll have ability to map these and show them more carefully. Okay, so this is a laminar defect. So if you look at the scan, you'll see the laminar defect popping up in a moment as it comes to the anterior. So there's actually little holes that show up and not just the usual slits. And with enhanced depth imaging, you get that view quite nicely. Now the other is swept source OCT, which gives you enhanced sampling as well. And with swept source, you can reconstruct the lamina cribrosa quite nicely. All right, so there's a number of things that in the future will help us as well. So just to summarize, when you're looking at these scans, keep in mind that until, maybe 10, 15 years ago, we only had really optic nerve to look at. Now we have this excellent ability to look at the rim and the ganglion cell, both peripapillary as well as the actual map in the ganglion in the macular area. And so first just confirm, like you would with any test, that it's the right patient, the proper age, date of birth, etc. was entered, the signal strength, and then check for any refractive errors. And if it's extreme hyperopia or myopia, then you need to take that into account when you're looking at the thickness of the nerve fiber layer. In myopia, it can be thinned just as a normal. And then look at rectangular or non-anatomical areas of absolute nerve fiber layer loss, like some of those black squares I was showing you, which are artifact from blinks or from media opacities. And those can create some serious challenges. Compare the fundus image to the thickness maps to make sure that the disc border is identified properly and everything corresponds. And then look at the T-SNP plot. Now, you need to look at the segmentation pattern, whether it was done properly or maybe there's a blood vessel or something that messed it up. And then look carefully at the plot and see if the plot makes sense. And if there is abnormalities, then check why. Now, if the RNFL is less than 40, that's probably some error, okay, because it's not almost never below that amount. Remember I talked about the floor effect. And recognize that there are errors as well in segmentation. We showed some examples of epiretinal membranes or other macular diseases, so you can keep that in mind for artifacts. Keep in mind that different machines have a different level in terms of quality, but also in terms of floor effects, and you need to know the machine well. And finally, I think in my practice, although I do utilize it as a standard to follow patients, it's not practical for all patients because of the socioeconomic background and challenge, with the costs. And so I tend to use it in those patients if I'm concerned about other pathology that's more complex, such as drusen, or myopic discs, where I want a bit more detail, or a suspect. I'm trying to decide, is this actually glaucoma, or is it, maybe a low risk or a high risk suspect? And if it's a high risk suspect, then that changes things for me, because then I'm more likely to treat or offer treatment, as opposed to low risk suspect. And stratifying a glaucoma suspect, I think the OCT can be quite helpful. Okay, and then as with other tests, a good baseline, which may require more than one test, especially if the quality is not great, and then following the patients over time. And I realize that, look, this is not practical necessarily for all the patients we see, but I hope this has given you some tips. And I just want to acknowledge my colleagues, Dr. Nicolella and Dr. Harasimowicz, who kindly shared a lot of the material, and the other material is referenced through the article. So thank you very much.
Thank you very much, Professor Danji.
that both been done dilated or undilated, and the quality of the image, because we see sometimes the scan's been done and it's undilated, and suddenly the quality of the picture or quality of the scan is different, and then it affects your results.
So my own feeling is that with visual fields, it definitely affects the results, right? And especially if you have large pupil size changes. With OCT, many of them can get through a small pupil pretty effectively. And I think it can have an effect, but the more significant effect is probably all the drops they've had. By the time somebody's dilated, they usually had the tonometry done, the dilating drops, their ocular surface may not be ideal. So I think just putting on some lubricants as a standard before the scan is probably more helpful to avoid too much change. But I'm not sure that the pupil size with these newer technologies and machines is all that significant, because certainly with field, when it's below 2.5, there's diffraction limiting size. But here, if we're just looking at the peripapillary scan, it seems pretty good, unless you have examples otherwise.
Yeah, no, I totally agree with you, and you explained it very well. So what not everybody have a SWEPS or OCT or Tritron or something. So normal 2D, 3D, OCTs originally. If you have a slightly dilated, undilated pupil with some media opacities, the image differences, there are certain differences which change the actual map of the appearance of the scan, and that suddenly becomes looks like a significant change. But when you look at back and the quality of the scan, actually the quality of scan is different rather than the actual deterioration. So people sometimes overtreat or undertreat because of the poor quality. What I'm trying to say is we do virtual clinics on the basis of all the images and everything being available to us, and data been captured, and I got a luxury of having a whole of my glaucoma data for 13 years, and I can plot everything on the Medisoft, what exactly happened when it started to finish until now. So what we noticed is one day the patient came, had a good scan, and then suddenly next time the next imager didn't do a good scan, and actually that scan showed significantly different appearance. And similarly, sometimes there was a bad scan and you had a good scan, and they will say, well, actually it looks better. The actual appearance hasn't changed, the actual disease hasn't changed, it's the scan quality. So what I'm trying to say, sometimes there's a lot of information in OCT scans. Don't always just treat the scan, treat the patient, and treat what is there in front of you, and treat the function, not only structure.
Yes, I agree completely. I think you have to look at the whole patient and treat based on structure, function, and the entire patient, not just the red disease or whatever. And also, I think you make a good point that if there's a cataract, for example, or a posterior subcapsular in particular, that may throw off the scan. So then dilating may make sense. But just like any good test, let's keep the parameters similar. If you're dilating, then just do it dilated all the time. And if you're not, then try and avoid the dilation. Similar would hold true for the visual field, right? Okay. So okay, so I actually don't know the answer to that. Clinically, when I examine these patients with nystagmus, I dampen their nystagmus just by pushing on the eye through the lid, right? Just to get a better view. With the OCT scan, it's not so easy unless the technician's very skilled. Unless there's eye tracking and registration that's done carefully also. There is some hope with virtual reality technology that in the future we will have better ways of tracking eye movement and actually doing pictures and scans as well. Right now we can do visual fields on virtual reality technology fairly well. So I don't have a good answer for you. Maybe some of my colleagues would like to comment on that question, unless you have another comment?
I don't think they're OCT nystagmus, especially with glaucoma. In macular mapping, maybe it's a bit quicker. But all OCT machines, including the SWEP source machines, they take significantly longer when doing the optic nerve. And in my practice, I tend to do OCT myself. And still, despite being very careful, if I see 10 patients, majority of them will have segmentation errors. And this is why when I used trend analysis, structural trend analysis of disc OCT, majority of patients, despite being done in my hands with topical anesthesia given to minimize the micro movements to avoid segmentation errors, it's a rarity that I find a reliable trend analysis. So, and the other thing that I would like to make it's my personal observation while discussing with my colleagues in Pakistan, that majority of them, they will have one single printout of OCT scan, and they're asking opinion on that. One OCT printout means nothing. It is nothing more than a traffic light, red, blue, and green.
And especially if it's coming from different institutions
Absolutely.
each time.
And this is why when Sadia was doing our fellowship, the emphasis was that if you're getting OCT done, get it done by the same machine, under the same roof, connected to the same server. Otherwise, there is no benefit.
And use the software
And
so that you can achieve the full
trend
benefit.
analysis.
Yeah.
And one more thing, in Pakistan, due to dust, the OCT sensitivity decreases very quickly, the machines. Within 1 year, if you do not get your service done, the sensitivity of the machine will reduce by 30 to 40%.
Because of atmospheric dust.
Yes, and this is why your segmentation errors will increase. So please have the servicing done regularly.
Good point. I know Dr. Mayer is going to make a point about the
I think
microscope.
I agree with you. We always advise you that you go on the same machine because, there's almost, even do the macula, there's a 20, 30 micron difference on different machine. So you cannot be sure about it, And the answer to your question is that I know there's one place in Karachi that when you send your patient to them, they always dilate and do it. So patient don't want to go OCT there because they say that our vision is knocked out for, say, for example, an hour or so. And we have seen in our clinic, we dilate them because we want to look at the opacity. The cornea is really done because optometrists check their IOP, then you look at the IOP. So when you send them for the OCT, and there are a lot of problems, and you leave that patient, even you put them TR natural 2 or whatever the case may be, you bring them after a couple of days, cornea is clear, and you see it, your scan quality is much better. So scan quality is something that we have to look very, very carefully. Yeah, the other problem is the patient with methanol poisoning. I have got patients, they cannot fixate it, and we have trouble getting their OCTs. We are interested to get their OCTs, and some of them, they cannot fixate, so we simply can't. And nystagmus can be really real difficult. Yeah.
No, and that's the benefit of having different ways of assessing structure function, right? We can't just rely on any one test, yeah.
Structure, no matter what, no matter how advanced you get, fundus photograph is still invaluable. Please do not underestimate the importance of a good digital photograph.
Yep. I think that's very good advice as a baseline for any patient coming in, right?
Well, Rashid, let me say that fundus photograph is not available in a lot of units in Karachi or Pakistan. What we advise is look at the disc. You got 90 diopter in every setup. Look at the disc. If the disc looks healthy, nice pink in color, there's a small cup, and doesn't matter whatever your OCT shows. And OCT will show one single paper thing, red. I tell the guys, look, this doesn't mean anything to me.
Well, if you don't have a camera, at least we can draw it.
Of course.
And if you can't draw it, then we don't have to have different color pencils, although that would be nice. But then just describe it at least, right? So.
And one very important thing in your lecture, you kindly mentioned that OCT has more sensitivity in early glaucoma. Once the disease progresses and the hits the floor effect, then you're just going to go through the OCT of the vascular bundle. You have already lost
Yeah.
a lot of neural bundle, and the machine is not sensitive enough to pick up further changes. So in more advanced diseases, rely heavily on vision field or function assessment. On early to moderate diseases, you can have similar effects with good OCT, serial OCT on the same surface, with the same software.
As a general rule, and I think the ganglion cell complex can help in some of the advanced cases, but I also rely more on the field at that point, yeah. Yes. Yes, that's true. And then after that, you don't need this test because patients are worried, right? Why aren't you doing this or what's happening? Yeah, that's a very good point. But it is a useless test at that point, unless if you're just looking at the RNFL, it's a waste of everybody's time and money. I think there's a few more cases, right? So
Right. Thank you very much,
Thank you.
Professor Damji. Now, the next presenter is Professor T.S. Meher from Aga Khan University.